And good evening, everybody, and welcome to this week's Maternity and Midwifery Hour. My name's Sue Macdonald, and I'm the curator for the Midwifery and Maternity Festivals and the Midwifery and Maternity Hours. And it's my pleasure to be chairing this evening's session, which is going to be really interesting, as it always is, but even more interesting, I think. You're joined by four wonderful speakers, and that's Sara Cummings, Monica Lakhanpaul, I hope I've pronounced that correctly, Monica, and Angie Utara and Belinda Gugi. And we always do this to our guests. We always ask them to share with us a moment of their week. So I'd like to do that. So can I start with Angie, who's at the top of my screen at the moment? Angie, would you share your moment of the week?
Good evening, everybody. My moment of the week is I had a really lovely trip back to where I trained to be a midwife in Bournemouth this weekend, and celebrated one of my very closest friends' 70th birthday. And she had so many flowers that I got some to bring home because she was very loved. So it was a great weekend.
Lovely. That's a lovely moment to share. Thank you so much. How about Sara? Could you share your moment?
Thanks. So, hello everybody to listening tonight. My moment of the week was probably getting my kids out in the snow at the weekend and watching my adrenaline-fueled 4-year-old build a little ramp for his sledge and getting a slow motion video of his little face as he launched off the ledge and went flying on his sledge into some snow. Just pure joy.
I love that. And it's good to remember there's snow in other parts of the UK, because at the moment in the south, it's just miserable and sort of a bit grey. So that's lovely. And you have evidence for the future when he's older. That's fantastic. Thank you so much. How about Monica? Have you got a good moment too?
I've got an interesting moment, slightly different because it's a bit warmer where I am at the moment. And today I was greeted by about 10 monkeys on the path in front of me. So that was a bit of a shock, a bit of a scream came out, and yeah, sort of retreated carefully before they took away my phone.
Oh gosh. Were they friendly? Or
I don't know. I got away.
Bit assertive, perhaps.
Yeah, a bit scary. A bit large with big tails.
Okay, fantastic. And I should say that Monica's come in from India to us. So it's very late at night for Monica. So a special thank you to Monica for joining us in the dead of the night too. Thank you. And Belinda, finally, your moment of the week.
Yeah, good evening, everyone. I had a really lovely day today, actually, and we had a group session, a baby and me session today, and we had lots of different mothers and babies come along, and we had a 2-year-old that's just recently arrived in the UK, and we had took a good liking to a little fire engine that we had, and he'd never seen anything like it, and he asked if he could take it home. So that was just really lovely to be able to see his face and him walk out with this lovely little fire engine toy that he'd never seen. So it was lovely.
Fantastic. Thank you so much. And thank you for sharing such a variety of wonderful moments, because that's making me feel really bubbly and joyful. And I'm sure our audience are feeling the same. So thank you so much. Now we're going to return to our speakers in a few moments. I'm going to do the usual thing of just reminding people where the Maternity and Midwifery Hour came from. And I say this because I know we've got some new people with us this evening. So welcome to new people. I hope this will be the first of many such meetings together, and I just want to tell people where we came from. We were part of the Maternity Midwifery Forum, and we've always run events and conferences and study days and things like that. But obviously with the COVID-19 lockdown of 2020, I can't believe that's 5 years ago now, we were facing not being able to provide anything face-to-face, and knowing that midwives and people in maternity services and student midwives also really needed something to connect and some means of getting information. And so we came up with an hour a week, which seemed like a really good idea at the time, and it's such a good idea we're still here, and the COVID lockdown is well over now, and there's COVID about, but it's not in the same situation as it was. And we've obviously moved our focus, so we don't talk so much about all the changes in the services and what maternity services are looking like with the changes. We're looking just about everything of interest to maternity services and midwives and student midwives and other people. And we welcome a lot of people from all over the world, so welcome to you. Also, I need to reinforce that everything that we do is recorded. So if you should have a power cut or you need to rush off in the middle of watching the maternity hour, you can catch up. And that's really been fantastic for our regular people, because they can access this anytime, day and night, if they wish, weekend, days off, whatever, and catch up. Also, it means that we have a huge back catalogue of really fantastic resources, which are fantastic if you're doing revalidation for midwives, or if you are doing a project, or if you're doing a dissertation or any such study. You can get a huge amount of information. You just need to go onto the Matflix resource, and that's a cue for me to remind you this is on your list of resources. And on your list of resources also, our speakers have very kindly provided some reading and some fantastic links for you to use after the hour. So fantastic for you, it is. And I'll just say also at this time, which I always also say, is a big thank you to those of you in the maternity services providing care. It's always a stressful time because we always seem to be short of staff. And of course, in the winter, people have got more colds and coughs and all the rest of it. So people have to cover sickness, and it's tougher. And everywhere's busier than ever it is. So a big thank you to everyone out there now. Now, I'm just going to do a very quick newsy, and you see him galloping, so I want to get on to the main event here. This week, we had the 80th anniversary of the liberation of Auschwitz-Birkenau and the Holocaust Memorial Day, and that was a very important day, and important to remember that we mustn't forget, if you like. And some of the images were very difficult to cope with, but of course, there are a lot of images around at the moment that are difficult to cope with as well. So I'm jumping along from that and on to Happy Chinese New Year. That's a bit of a sort of juxtaposition, but it's the year of the snake, apparently. And so for those of our Chinese viewers, a Happy New Year to you. And also I need to now, because I've got 2 minutes now till our speakers are going to speak, very relevant, and I know that this is going to be discussed by our colleagues tonight. Something that hit me on the news yesterday was the National Child Mortality Database's figures talking about the increased mortality for babies and children living in temporary accommodation. 74 children had died and 58 were under 1 year old. And I think Monica's going to talk a bit more about that, but it's quite stunning that that's happening for people. Maternity, you can say maternity or families, women and families. So I think it's a really important issue that we're looking at. So we're going to be looking this evening at homelessness in pregnancy in the early years. And we're very privileged this evening because we've got 2 clinical researchers talking about their recent research into pregnancy and homelessness and families under 5s in temporary accommodation, and also 2 key workers from key third sector organisations supporting homeless families in the UK, who are also sharing their practical, very, very practical experiences of supporting pregnant women and families. And this really, for me, illustrates what is needed and what is so important, because it might look as though, you know, very disparate groups of people looking at this area and helping out in this area, but it's the kind of themes and the multidisciplinary working are crucial to addressing this very complex issue. So I'm going to, first of all, introduce, and I'm delighted to do so, and welcome Sara Cumming, who's a registered midwife and researcher. She's worked in London, Brighton and Tayside, and she now is working in maternal health research with the Mother, Infant and Child Research Unit, which is the MIRU, at the University of Dundee. And she is passionate about reducing health policies for marginalised women and families, and in 2021 she received funding from the Wellbeing of Women Royal College of Midwives entry-level scholarship for midwives to conduct qualitative research exploring homeless women's experience of pregnancy in temporary accommodation. So welcome, Sara. The screen is now yours. Thank you for coming this evening.
Thank you, Sue, for the introduction. So really just want to start by saying thank you to everybody coming to listen tonight. There's no doubt that it's a very important and contemporaneous topic that we all care about. So I'm going to start what is a group presentation tonight. And I just want to highlight that although we all work separately, our work unites with a shared focus on supporting pregnant mothers, children and families experiencing homelessness. So as Sue said, myself and Monica will be highlighting our research in this area, whilst Belinda and Angie will give an overview of working in the third sector. But really what unites our work is the core belief that being pregnant or living with children in homeless temporary accommodation has specific challenges and detrimental health impacts for pregnant women and children that need more understanding, needs more research, more support and more response from both health services and the government. So I'll be talking about health impacts and barriers to accessing care whilst pregnant and homeless, based on qualitative research I led with University of Dundee's Mother, Infant and Child Research Group. And I want to acknowledge the research was funded by Wellbeing of Women, Royal College of Midwives and Burdett Trust for Nursing, and to thank Wellbeing of Women for their support with this project. However, first, I think it's really important to contextualise this research and highlight why we need to have a gendered lens on homelessness so that we can acknowledge the structural inequalities shaping women's homelessness. So women are considered more at risk of homelessness because of economic inequalities. They're more likely to have caring responsibilities, and as a result of those caring responsibilities, they may face increased financial disadvantage because of part-time or precarious work. So they're less likely to be homeowners in the UK. Pregnant women are further at risk of homelessness because of the known rise in domestic violence and relationship breakdown that occurs during pregnancy. However, homeless data is often based on formal homeless applications to local authorities. And what we know from previous research is that women with children are less likely to make formal homeless applications because of fear of child removal if they present themselves to services. Instead, what we know is that women are more likely to resort to informal solutions to their homelessness, so surfing with friends or with family. And that means they won't show up in government data around homelessness because they haven't made a formal homeless application. And when we think about women who might not have recourse to public funds, as Belinda will highlight later, they are even more invisible from the data. So this really perpetuates this absence of women and pregnant mothers from the homeless data and continues an underrepresentation of their needs in homeless services, research and policy. So we know actually very little about the numbers of pregnant women facing homelessness in the UK because they're not recorded. Pregnant women are included in family homeless statistics. And I know my co-presenters tonight are going to present some of those statistics. So I would just share from a Scottish perspective that in 2024, 30% of the households in temporary accommodation were families. So that's pregnant women and children. And that's a 5% increase from 2023 alone. So homelessness is an increasing clinical concern for maternity healthcare professionals. What we know from previous research is that homelessness in pregnancy is associated with an increased risk of stillbirth, preterm birth, and poorer outcomes for both mother and baby. However, there has been a tendency to focus primarily on street sleeping as the only form of homelessness in research and to emphasise fetal outcomes only. So my research design was really grounded in a critical feminist and an interpretivist paradigm and used qualitative methods to really make sure that the voices and the lived experience of pregnant mothers were at the centre. How did they feel about homelessness impacting their pregnancy? So between December 2022 and March 2023, I conducted 14 semi-structured interviews with mothers across the UK who had experienced homelessness in pregnancy within the last 2 years, and with 6 key workers from charities that support homeless women. This current research is actually under review for publication, so I can't go into depth about the actual analysis procedures or the findings from the thematic analysis, but what I will be presenting to you tonight is one of the key research outputs, which was an infographic for midwives and maternity healthcare professionals that was co-produced with the mothers in the research and the lived experience group of mothers. And that infographic is currently open access and available via a QR code at the end. So if we look at health impacts in pregnancy first, thinking about physical health impacts. So poor housing standards in temporary accommodation are common, meaning that pregnant women can be exposed to environmental hazards such as damp, mould and vermin. They may also be regularly exposed to passive smoking risks, and that includes drug smokes in communal areas. All the mothers in this piece of research reported feeling worried and anxious about what impact these environmental hazards had on their unborn baby. Physical health in pregnancy can also be impacted by reduced nutritional intake because there is a lack of access to cooking facilities in temporary accommodation. Some of the women had shared kitchens, but they couldn't take their children into the shared kitchens. It wasn't allowed, or there were strict rotas about who could access it when. And some of the women had access only to kettles in bedrooms, and some women who were in hotels had only access to meals at set times and no access to food outside of these times. And all this is compounded by limited financial resources with which to buy additional food. And then thinking about well-being impacts, these mothers reported stress and anxiety from constant housing insecurity, feeling unsafe where they were staying in shared accommodation, and sometimes this was mixed gendered shared accommodation as well. So they self-isolated in these overcrowded conditions and cramped rooms, and all the mothers in this research linked their living conditions directly to poor perinatal mental health in pregnancy. Thinking about barriers to accessing maternity care, frequently moving is very common whilst homeless. 3 of the women in this research were moved 6 times during that one pregnancy, and 2 of those women were moved at 36 and 38 weeks pregnant. So this is obviously physically and mentally stressful, but the mothers in the research also revealed a sense of feeling that local authorities didn't appreciate their increased need for a secure home before birth. Both of those women who were moved just weeks before giving birth were not giving any extra time other than the usual 24 hours notice to be out of one property and into another. And that they said that left them feeling very unseen and dehumanized by the system. Obviously, frequent moves also disrupts antenatal care. They may have to register with new healthcare services, and that can delay access to routine midwifery care, to scans, to screening tests, access to repeat prescriptions, and really importantly, it may create barriers in seeking midwifery care in the context of reduced fetal movements, especially if they've just been moved to a new area and they don't know how to contact triage yet. And it's really important to note that although proof of address is not a legal requirement for registering at a GP, it's still a commonly reported barrier to accessing care whilst homeless. In the context of referrals, the referrals may be sent to old addresses that pregnant women have moved on from. So it's really important to look at those causes of did not attend at the level of the system, not at the level of the individual. And then finally, a further barrier was lack of internet access in temporary accommodation, which can make accessing digital maternity notes like Badgernet very difficult. And that left women feeling unable to make informed choices about decisions around their care plans. This next part of the infographic really summarises what the pregnant mothers said about how challenging it can be to engage with midwifery services and maternity healthcare professionals, because there's so much fear of judgment and stigma and fear of child removal, as well as this constant stress and anxiety of not knowing where they would actually be housed once the baby was born. And we know that previous research has highlighted that high levels of stress in pregnancy can have a detrimental effect in utero and in the early years. So really, how can we as midwives and maternity healthcare professionals support pregnant women experiencing homelessness? This final part of the infographic really summarised what the pregnant mothers in the research identified were their key needs from their midwifery care and maternity services. For the purposes of time tonight, I'm just going to emphasise 2 key points here. Pregnant women may find it actually really helpful to be asked directly about their living conditions, because this overcomes barriers of stigma and fear of child removal, because the midwife is opening up the conversation. So think about asking, do you feel safe where you're currently living? Have you got somewhere safe and warm for baby to sleep? And the final point that I'd like to share from the women is this power of feeling seen and heard, because quite often they feel unseen in housing systems. They often felt that local authorities and the homeless system didn't really understand their specific needs in pregnancy or prioritise their need for a safe and secure home before the baby was born. So every interaction with a maternity healthcare professional then became an opportunity to counteract that sense of feeling unseen and unheard. And often it was the small acts that really impacted the mothers. So, for example, the triage midwife who'd arranged a side room in early labour because she understood that home was not a safe space for that woman to go back to that would help labour establish. Or the maternity care assistant who changed her rota around so she made sure that she did all the postnatal feeding support visits because she could see how distressing it was for the mother to have to keep repeating her story of why she was sleeping on a sofa. Or the community midwife who wrote multiple times to the council to express concerns about where the mother was living. All these acts may or may not change their situation, but the real impact that the mothers shared was that they said it made them feel supported, it made them feel seen, and it made them feel heard in their midwifery care. And the impact of that should never be underestimated. So I will end there with a link to the infographic and some references and some further reading, and I will hand over to my co-presenters tonight and look forward to some questions coming up soon. Thank you for your time.
I don't know how the audience are feeling, but I'm already feeling stressed just at the thought. You think about if you move house, how stressful it is. Just one move, and thinking about these women having to experience this level of change. So thank you so much for starting things off. And out there, if you have some questions for Sara, just post them in the little chat box and Paul will feed them through to me, and then we can have this in the end of discussion, as we always do. Okay, so without further ado, I'm going to introduce with great pleasure Monica Lakhanpaul. I hope I've pronounced that correctly, Monica, who's Professor of Integrated Community Child Health at UCL, Great Ormond Street Institute of Child Health, Consultant Paediatrician, and NIHR Strategic specialty co-lead for children. And Monica works at the intersections of health, education and the environment, supported by citizen science and the creative arts to involve the community she works with directly in co-developing the solutions aimed at supporting them and improving their health and well-being. For many years, she has led the Champions Project, exploring the impact of children living in temporary accommodation, advocating for action and change. And you'll see, and this is a point for me to say, have a look at the website to see the full CVs of all of our guests, because there's more about Monica. It's a real pioneer and there's lots of information there. And of course, she's joined us from India tonight, and thank you so much. This is the middle of the night for Monica. Welcome. The screen is now yours.
Am I unmuted now? Hello? Perfect. So thank you everybody for joining us this evening. As we've just heard, it's a terrible situation that we're finding ourselves in, with mothers and then their children living in these dire circumstances. And as this title says, a home should be a safe space for children in their early years, yet these children are not in a safe space. And it's a tragedy, really, that we need to be tackling. I'm here on behalf of all the Champions team, others who contributed just as much as me to this work. So just want to thank them and speaking on their behalf this evening. My slide won't move. So this is just really to ground us in really what are we talking about. We've talked about women who are pregnant, but those women then give birth to a child, and the child's growth starts within the womb, and everything that's happening to the mother's stress, what she's eating, the environment she's in, is going to impact on the child later on as well, through their infancy, through their toddlerhood, and through adulthood. And this is why it's such an important reason why we're all here today, talking not only about the pregnancy, but also the early years of a child as well. Now, we heard earlier about the tragic news that was only a couple of days ago, really, that so many of our children in this country are actually dying because they are in temporary accommodation. So there's 80 children who died in temporary accommodation in 1 year, but actually the numbers of children under 1 who've had temporary accommodation actually contributing as a cause of their death is actually too high and really should not be allowed. And so it's something that we need to be tackling at this current moment in time. And it's just sad, actually, that this news only came out in the last few days before we're having this presentation today. So it really makes us think about why we're all here. This slide here really just shows you about the different impact of living in a homeless environment and in temporary accommodation can have at different ages. So we've mentioned some of them today: stress, stigma, isolation, and you'll hear a lot about that as well from my colleagues later on. But also, what about the actual births? Higher number of babies being born who are premature, low birth weight babies, stillbirths, and also disrupted attachments that then go on to impact on the child later. And as the children grow as well, they're missing immunizations, they're having developmental delays, chronic health issues, and lower GP registrations. And I'll come and talk a bit more about that in a second. So we have 2 projects going on. One, the overarching project, which is the Champions project. And beneath that, we've started another project as well called PSP Refugee. And this particular project focused particularly on refugee and asylum seekers who are living in insecure accommodation. But some of the early findings, and these are very early insights into what we're finding at the moment, we're still analysing the data, but some of the information that we're already finding are similar to what we found from our other project around the inadequate nutrition, the serious safety risks that we're finding for the children living in these accommodations, the risks to physical health and development, and I'll go into that a little bit more. Survival without enrichment, we've used that word very, very carefully. The children are being cared for by their parents as the best those parents can in the environments they're in. But if you don't have all of the other added nurturing packages around you, the warmth, the safety, all of the other things we're talking about, the building blocks, that enriched early years is difficult to have. And that then impacts on the risk to emotional well-being as well. So what did we find, just to break it down? Well, we've already talked about the fact that there's limited food availability, and this is often because of not being able to store food in fridges. We've heard stories of food being hung out of windows so that they can keep the food cold, having to eat tins because you can't have other healthy food, keeping the food clean because there are cockroaches or other vermin running around in the cupboards. No consistency. You can't actually have a bring your child up with fitting into the Healthy Child program as we all try and promote, because how do you have a consistency in the way that you're bringing your child up, especially for nutrition and feeding habits? Shared spaces mean that sometimes it's difficult to go and prepare hygienic food and actually feed your child in a timely way when they're hungry and they need to be fed. And no play areas, and we'll come to that in a minute, but no laundry either areas outside where you can go and easily access washing those clothes. A baby needs to have their clothes washed frequently. They vomit, they get ill, but many times the families can't get access to washing machines and drying facilities, which then put a risk to the children as well. Then we have relationships and development. The children are in very small environments, overcrowded, sleeping together, sharing beds, sharing rooms. That not only puts the child at risk from overcrowding because they're sleeping in the same beds with each other, which we know that we try not to promote, but what can they do? But it also means that relationships break down. They fight with each other and have a higher stress level than maybe what you would if you had space and room to separate yourselves and really de-stress in difficult times. So that means that parents get stressed, the mother gets stressed, the children get stressed. And really, we can all imagine how that is if you're not able to release that in any sensible way that really supports your emotions that you're dealing with. Some of the children are so frightened living in these little accommodations that they've heard noises around them from other people. They hear the shouting, or they see the people when they walk down the corridors. And that means they withdraw from others, and they become not used to interacting with other children or even other adults as well. So when they grow, when they interact, they may be a bit more behaving in a little bit more of a fearful way when they're actually around other people, which then is difficult when they grow up to being in school as well. So as I've mentioned, there are noises, and I talk about what we hear, what we see, what we smell. And these are all of the things that are around these children that make it very difficult for them in their emotional well-being to then feel safe in their homes. We did another project as well, which was called the REACH project, which was around play and play facilities. And we know that during COVID, many of these play facilities were closed down, and many of them have not opened up again. Many of the homes and shared accommodations that the children are in don't have any space for even the babies to go and crawl around, which impacts on their development as well. So if they can't crawl, they can't toddle around, they can't play with other children, they can't play with other toys, this impacts on their development as they grow. You're in accommodation where you're spending more time indoors because you may not be able to access parks or go out so easily. And this has an impact on the level of vitamin D in the children as well. They also may not be able to exercise them as much, which has an impact on the growth of their bones, can impact on sleep problems as well, and their behavior. And there, as we've said, you know, the problem then is that they may miss on those interactions with other children, and that support group for the mums as well doesn't actually come together. So some mothers have said, as we've heard, that you move from place to place to place. You can't develop relationships with other mothers. You can't develop a support system that you would normally do. And that impacts on your parental mental health and sometimes your self-esteem about yourself as a parent. And that's not the mother's fault. And it's our job really to find a way of finding a way not to move families and mothers so often as we do at the moment. So another area that we were talking about a lot in our project, which was around mental health again. Children do have mental health, and we don't really talk about that a lot. We talk about parental mental health. But of course, parents have to have the capacity to be able to look after their child. The child then feels sometimes unsafe, unhappy, frustrated. They feel anxious. They can then have separation anxiety, and they can have attachment issues as well. And this all starts from when the baby is before they're born, and then through to their birth, and then through to their early years as well. So what were the key challenges in a summary from some other work we've been doing this year? Lack of a permanent location. This is a key, really, having to move from place to place very quickly, and having to also, you shouldn't have to have a proof of where you live for GP surgeries, but sometimes they still ask for this and they're not meant to. Fear of discrimination, women feeling that they're discouraged from seeking healthcare, and they feel that they're going to be discriminated against, or there's a power imbalance. Resource limitations, where they don't have internet connection, where often that's where they get their information from about how to navigate the system or how to look after their child when their child might be ill. Social barriers, where family and community support groups, as we've said, are not there, which is so important for mothers during these difficult times. And that again impacts on maternal capacity. They may also be having some issues with partners around partner violence. We know about the journeys of refugees and asylum seekers. So they're dealing with many of the problems, as well as maintaining their other health and supporting their baby's health as well. So what did the families say that they wanted? They wanted child-friendly accommodation. They wanted places and spaces where the child could play indoors and outdoors. They needed their own kitchen and bathroom. Bathroom is something that we need to talk about more. Mothers and children were telling us that really having a dirty bathroom, which is often shared, was unhygienic. They didn't want to go in the bathroom. Children were going to the toilet in cupboards, even the older children in cupboards in the bedroom because they were too frightened. And that obviously puts a risk to the child's health with sore bottoms or urine infections, constipation, etc. Places to cook healthy food. You know, the early years are so important for healthy feeding. Women were talking about the difficulties with breastfeeding. Where do I breastfeed? Where can I feel comfortable feeding my child when we're in a crowded space and there's no other room to breastfeed my child in? No place to dry the clothes, which gives mold on the wall. Get mold on the walls, you have breathing problems for the family as a whole, not just the children, but also as the parents as well. And they really felt there needs to be a change to the system, and that's where we come in. It's our duty to change the system. We need to be thinking about integrated systems, working together, midwives, health visitors, paediatricians, housing, education, social care. We need to be becoming better at exchanging information and sharing information. They felt there needs to be a cap for the duration of time families are in TA, and there needs to be a link worker to help them hand over when they move from place to place to place. So we came up with this very simple framework, which I hope will be useful to you, but it was called the SHE framework. And what this really just says is all children should be safe, healthy, and educated. And that means that children shouldn't be in an environment where they're frightened, where they feel that they're going to be impacted on for being around other people who they're scared of. They have to have a safe internal environment. We've heard about the mortality data today, and so we really need to be doing something about this, so children are not dying in temporary accommodation. Children should have the right to be healthy, and it's our duty to enable that to happen. And they also need to be educated. And when I say educated, I'm talking about their development as well. They need to be able to play, they need to be able to communicate, they need to be able to socialize. So on that, we created this sheet, and this is again on our website, where it just talks about the SHE framework and the tips that you can hand out to your families as well. And we developed, and we're very lucky to have a wonderful consortium of project supporters. So I just want to thank them all for supporting our work and our ongoing work as well. We are continuing some work in Scotland with Shelter as well to hear the voices directly from the children. So thank you again, and back to you. So I hand over to my colleagues now.
Okay, that's stunning. And I thought that last sheet, I was looking at it very carefully and thinking that's really very useful for practitioners and for the families as well. Fantastic. I suspect there might be some questions about that coming in. So thank you so much for kicking us off with that. And so I'll now welcome Angie Otara, who's an experienced midwife and focused care practitioner, passionate about giving babies the best start in life. Her current role focuses on supporting pregnant women and babies to thrive, delivering frontline care in addition to developing and improving healthcare pathways. Welcome, Angie. The screen is now yours.
Just unmute. Good evening, everybody, and thank you for welcoming us. I'm just really excited to be here and to be sharing and building on what Monica and Sara have already shared. We're a very practical response to the homeless journey for families, and we're based in the northwest of England in Oldham. Shared Health Foundation is a community interest company, and we're philanthropically funded. And Dr. Laura Nielsen heads up our team. We're really passionate about looking at how we reduce the impact of health poverty impact on health inequalities. Nice. Not moving. So I've been a midwife since 1998, and I've always worked in practice in community and antenatal, and have always been really, really passionate about the most vulnerable women that run through our communities, really, in inner city areas. And as I worked over the last decades, I became more and more frustrated, really, at seeing that revolving door around where families came through. And at the beginning of the pandemic, was really blessed to be able to come and work for Shared Health Foundation, and to start looking at homeless families. And who would have known that under that umbrella of homeless families are all the most vulnerable women that we care for within our communities. A generation of children being born into a homeless system with little hope of a place to call home. Just some numbers to start with. I know that Sara and Monica have covered some of this, but these are the most up-to-date numbers that we know from July 2024. 159,000 children in temporary accommodation across the UK. And when we started in 2020, that was around 127,000. So just in the last 3 or 4 years, we can see the numbers increasing. And as Sarah said before, it's really difficult for those hidden numbers to be seen. So we know that there's around 20,000 babies being born into temporary accommodation, but I really don't think that's accurate. And as we've said, women being afraid to report and to register as homeless, sofa surfing with overcrowded families. So the numbers are probably not correct. But what we've also realised in the work of shared health is that if it's not being recorded, then who is interested? And this has been part of our journey as we've built the project and the response on the ground. So the sister company to Shared Health is Focus Care, and this is a model of care that we have run for over a decade in Greater Manchester and across in Dublin and Brighton. And Focus Care is embedded within GP practices, and we look at making the invisible visible within the general population. We're evidence-based, and we know that we talk to the doctors in those GP practices about those heart drop patients. And then what we do is we try to come alongside those patients and look to improve their health outcomes, access to universal screening, access to correct pathways for medication, all of those different areas where we know that barriers exist for the most vulnerable. So we adapted Focus Care and we started to look at what that would look like for homeless families as we started to work and see how many children were being placed in mixed accommodation, in B&Bs. We knew that there needed to be a different response, a response that looked at how health was impacted, how the barriers to accessing health through the system of homelessness could be made easier for the most vulnerable within our communities. And that's where our project for homeless families came about. Around the same time as we came out of the first lockdown, we were approached by NHS Properties, and this gave the perfect opportunity to pilot the crib. In the original days, we were called the Healthy Gems Hub, and this partnership was to use unused spaces within the NHS to look at providing services and working alongside, in partnership, multidisciplinary, to provide what they called a social prescribing response. So we looked at Focus Care, working alongside families, embedded within local authority, and we started to see how we could implement Focus Care to walk with families through the journey of being placed in emergency accommodation right the way through to a tenancy. For some, temporary accommodation is between 6 and 9 months, but for many, it can be anywhere above a year. We've seen families that are still placed in temporary accommodation 5 years in. So this space allowed us to invite families, when we've talked previously about families being in one room, not having play space, not being able to access somewhere to clean their clothes or use a washing machine. And so this space allowed us to be able to welcome those families and do really bespoke work with them and to look for those windows of opportunity, to look upstream so that we could mitigate all of the impact of those adverse experiences for those families, but also the homeless journey, and really look to remove those barriers and help them to improve the situations in which they were living. The space offered us the ability to run a baby bank so we could respond to real practical need and crisis. Often we know that families need that therapeutic relationship. They need to know that they're cared for before they will start to trust and let you into the other aspects of what's going on in their lives. It also allowed us to be able to host other services that offered restorative courses, for example, courses around domestic violence, courses around teenage behaviour, courses around baby bonding. So it allowed us to facilitate a space that we could welcome families, but then also welcome other services to work with us to remove those barriers. We were very blessed that we had a room that we could use for therapy. And as we all know, there are many delays in getting families and individuals into therapy. But what we saw was with the ability to just hold them in that space, they were able to make the next right decision. Many of our families and our women didn't have that person that they could go to for that advice that is really directing them to the next right decision. Often they would need somebody just to hold them in that space. And so as we did that, and as we found that space for women, we were then able to help them make decisions around sexual health, around family planning. Again, all of these services were difficult to access. And again, we've referred to that previous speakers around GP access, accessing to get implants, accessing to get children up to date with their immunisations, long-term conditions. We saw all of these gaps, and we were able to step in and provide them in an actual building. We looked towards doing a step-by-step approach to reduce those inequalities for families. What we knew is, like we said, without that relationship, without that trust, there was so much worry and concern about whether their children would be removed. So as we started with that crisis provision, it was really important, we found, in the response of families and the response of women to actually then making that comment as they left. Oh, I've just got this lump here. Or could you help me with this? After we'd made that initial connect. And because we were based below the medical practice, it was a really easy route then to be able to take women if there was need for them to have appointments or to be registered. We also put them at the centre. We do a household approach. So we put them at the centre of the decision making, hoping to empower them, that there is hope for the future. But what we know is when housing is unstable and not safe, when we know we don't have a place to call home, it's very difficult then to set goals and the future and look to what can come. So we find often hopelessness is something that is really embedded within our families. And so that journey of trusting and being with them on the journey from the emergency accommodation where they can't cook, they can't rest in a separate room to the children or the baby, to be able to just come alongside them and be able to walk that journey and offer solutions, practical solutions, became really important. Just a little as to why we were called the Crib. We were originally called the Healthy Gems Hub, and with the commissioning of the family hubs, that it became really confusing. We are really small as a community interest company, philanthropically funded, as I've said. And so we needed to just make sure that that confusion for professionals and multi-agency working was removed. I am a little bit old, so I remember MTV and Pimp My Crib. But the Urban Dictionary definition of that is a house or a dwelling where one lives in their neighbourhood. And I quite like that alongside the work that we've been doing to create system change and also look at safer sleep, which we'll go on to in a little bit. So that's just why the Crib. Some people love it, some people hate it. A little snapshot of some of the work that we've been doing. So we've seen over 400 families since we've established. Obviously, there's been a lot of work to work alongside local authority and to bring a health perspective for the first time, I feel, to the way in which housing looks at their families within their care. Many of the actions that focus care we do as focus care practitioners is to look at that registry with GP practice, sexual health, as we've said. But we started to see lots of women who were pregnant, who didn't have access, who weren't able because they'd been moved or they'd fled domestic violence, or because they had been moved 3 or 4 times out of borough because they needed to find they just had no control. And so I think many people don't realise that there's absolutely no control for these families as to where they are placed, and that impacts on all of the different services and health access that they're able to go to and access. Some numbers just on some of the practical provisions that we've given. Infant formula, and again, we follow guidance around that. A wider context, optimum nutrition, vitamin D, but also looking at babies under the age of stage 1 formula to ensure that they are covered. And just to ensure as well that when we know, if we think in the wider context of families having to access food banks, many food banks, so absolutely no provision for babies and children, and they give absolutely have had to reduce the scoops, have had to make a decision on whether or not that room is warm or that baby there's one less scoop to make that milk last a little bit longer. Safer sleep guidance, we'll talk about that a little bit more, but every cot and Moses basket, what we started to realise from the earliest days of the provisions we were giving through Baby Bank was because of the financial hardship, women didn't and families didn't have the opportunity to make that decision around safer sleep. And even if they did, sometimes they didn't want to place their baby in that cot because they feared that it was dirty or not clean. So there was lots of parts of the puzzle that we were starting to unpick that we needed to look at. And this is some of the response that we've made in the time that we've been established. Sara and Monica have touched on some of these. So the themes that are continuous that we see throughout the journey, and that is preconception, antenatal delivery and postnatal, missed confirmation of pregnancy. Again, if you are in the homeless journey, you're seen as priority if you're pregnant. But if nobody has confirmed that for you, then quite often that's not accepted. Or in the early days of the pandemic, that's where we found ourselves. Missed booking appointments, which then had a knock-on effect to screening and then scans, saving babies' lives. All of these different vital components of the maternity journey were missed or were delayed at different points. And we see this time and time again. Access to hospital, being moved just before delivery. I think Sara mentioned about being moved at 37 weeks, 38 weeks, when every mother just wants to nurture and just make sure that they're nesting and they're ready and they're prepared. And then within 4 hours, we've had women who have been moved out of borough. Uncertainty around the new location, not being able to access. And again, we see those women that are in households where they are lone females with other children, where there is no childcare support. Where do you place those children when you are going into labour? What we see time and time again is the safeguarding issues around who those children are left with. And often in that situation, women will make the least worrying move to leave children. We've had women leave children with the woman in the next room because she was nice to me, or a woman that I met in the shop across the road because she was kind. So again, the safeguarding, will my children be taken away? All of these barriers, all of these problems surface time and time again. And in the postnatal period, we've had women discharged to a bed for every night, women discharged to hotels with no phone, no contacts. We've had women who have been, the discharge process has not been followed. Poor standards of accommodation, hot radiators, that regulation of the temperature in the room is nigh on impossible because that's regulated by the building that they're placed in. Missed PKUs, missed weights, babies and observations, breastfeeding interrupted because they're not allowed support and not allowed people to visit or stay with them. So isolation, feeling of being alone in that new environment as a new mum, not having anybody to stand with them and to just prepare food for them. There's nowhere to store food, there's nowhere to cook food. All of these issues impact our ladies all the time, and we have to navigate that with them each and every time they're discharged from hospital. I thought that I would share a little case study, and I hope you can see this picture because it's a prime little example of what happened at Christmas. So this family was not on my caseload, they were out of area, but the midwife who had been seeing this lady antenatally knew that I ran a baby bank and knew that she didn't have any Moses baskets. So I got the call and went in and provided the items that they needed under financial hardship. Their country of origin was Mauritius, first language Creole, limited English, but a good level of English mum had. And it's just to highlight what happened to them. So in the week before delivery, they were in a second floor flat, and they were moved a week before delivery up to the third floor flat in the same building. For what reason, we are not sure. She then went into hospital and delivered by cesarean section. And she was discharged from hospital day one with these low birth weight twins that you can see just on the side here. On the day that she delivered, the local authority decided to change her temporary accommodation. And they changed it to what I would suggest is equivalent to an Airbnb in the countryside, beautiful fireplace, spiral staircase. But first day home after delivery, cesarean section with twin babies, this is where the family were placed. So Dad had to leave the hospital, move all of their belongings with their 3-year-old, and then take his wife and babies home. 2 buses to the nearest town or the nearest GP. And then when she'd phoned me, like I say, she wasn't on my caseload, but when she phoned me, I arranged to go and meet her on the Monday. On the Monday when I got there, she hadn't been visited. It was day 8, and she hadn't been visited because the new accommodation, the new temporary accommodation, was out of borough to where she'd actually delivered. So these babies hadn't been seen. So it then took over an hour to try and locate where we needed to get through to the numbers to try and get this lady seen. On the day that they visited was day 9, the following day. And one of the twins was admitted with neonatal jaundice. And mum and babies had to go back in. Breastfeeding was disrupted. This lady was a really competent mum. She was really on the ball with things, and she was a lovely she's a lovely lady. But she said that she felt like one of her babies could have died. Her experience of that will stay with her in her testimony, and we're following that through. So that process of discharge wasn't followed. She did have the same phone number. The midwife had gone out, had gone to the other address, and then in that had told her that they had been moved, and that's where communication broke down. And I've just put the embrace there. We know NICE guidelines. We know that not much has changed over the last few years. We know that women being seen early, good communication, women put central to their cares and concerns, the right specialist pathways to be followed, language, communication. They're all the things here that obviously for this family, the babies are doing well and they're putting on weight. But mum has had an experience there which we hope won't happen again for others. I've just placed quickly up here. So if you ever get to come and see us in person, we often do this just as a bit of an icebreaker for individuals to look at, and we call it Badger or Baby. And it's basically to just talk through the fact that how do we change systems? And what we know is, ironically, the notes that women have are called Badger notes. And what we see in law is that legislation covers badgers more than it covers babies. So babies can be moved at any point in pregnancy, but badgers, if mother is pregnant, they can't be moved. And so it's just to highlight, in the slides you'll have later, but it's just to show how there is more work to do, and how do we change the system? And you can have a read of that. This last slide is just to show the process by which, with Safer Sleep, how we worked through to the All Parliamentary Political Group, how we worked with the NCMD, how we looked to raise awareness, politicians working to champion our families. And the process is long and hard, but actually what we have now is embrace recording where babies are when they pass. We do now look at NCMD to look at the numbers of and the related causes of death, and that's where the latest figures have come from. We do have a growing body of evidence, and we do have a growing number of politicians and MPs that are supporting the work that we do. And last year, at April 24, Amnesty International took on the call and created this resource, which you can click on after if you would like to raise awareness. Attention is growing. Homeless families are on the agenda. As we move forward, we know that we can improve things for families and for babies and women as they pass through the journey of homelessness. Thank you for your time.
Thank you so much, Angie. Fantastic. And I thought the case study really pulled everything together so vividly. Thank you for sharing that, because that was a really good illustration of, you couldn't make it up really, could you? You just couldn't, especially the spiral staircase. That was really quite amazing. So thank you for that. Now we're going to move swiftly on to Belinda. And just to remind people who are here, you might think, oh, they're running a bit late today. And I should have said right at the beginning, we always meant to run a little late, and it's a big topic. And you may well want to replay this again, and you'll have the opportunity because the link will be sent to you, because you'll probably want to go through a lot of these slides again. There's so much information, and it's important information that we need as midwives and student midwives to know. So without further ado, I'm delighted that Belinda Gugi is with us also. She's with the NCT. She's worked in the London Borough of Newham, supporting parents through various leadership roles, establishing services including infant feeding and perinatal mental health, peer support. And more recently, Belinda has developed Newham Nurture, I love that, a community partnership perinatal programme co-produced with experts by experience, supporting migrant and marginalised women during the transition to parenthood, which received a Maternity Service of Sanctuary Award in 2022 for its innovative and inclusive approach. So thank you so much, Belinda, for being with us. The screen is now yours.
Thank you so much, everybody. I'll try to be as quick as I can. Thank you for the introduction. So Newham Nurture Program, I'd like to share with you about the program. We're in the London Borough of Newham. So we're in East London. We're a community partnership with NCT, which is National Childbirth Trust, and local grassroots charities, Alternative Trust East London and the Magpie Project. So the program supports women and birthing people through pregnancy and up to 2 years after birth from low-income, migrant and marginalised backgrounds experiencing financial hardship and disadvantage. So we are a targeted service. All of the women we support are refugees or asylum seekers or have no recourse to public funds. Through the presentation, I'll be referring to women as this is how our beneficiaries self-identify. So Newham Nurture responds to well-documented inequalities in maternal and early childhood outcomes and barriers to accessing perinatal services for marginalised migrant women. So co-production is at the heart of all we do, and it's ongoing and it permeates through the service. On the screen, you can see this is just some of the words from our steering group. So the heart of the project is our co-production model to service delivery, which was adopted from the project's creation in February 2021 and ensures that the service is truly accessible, inclusive, and able to respond to the complex needs of the women that we support. So we have a steering group of women with lived experience of the hardships, challenges, and barriers that we've already heard much about that the new migrant families face and need to overcome when accessing maternity care. So the Newham Nurture approach aims to reduce every barrier stopping women from accessing maternity care and mitigating these through key practices within service delivery that really enable true access and inclusion for women and birthing people. So the service provides a real parent-centred, trauma-informed approach, enabling women to have their individual needs met, providing a safe, culturally sensitive and community space. Our co-led approach means that we're always able to be listening, learning, we're evolving, and we're improving the service to even better meet our target community's needs. We have quarterly focus groups to ensure clients' feedback and experiences are at the heart of the service and are fed into the steering group that provides co-leadership into the service design and the delivery. But a commitment to true co-production really works and takes significant effort, but through our experiences can also provide significant rewards, leading to really innovative new approaches in tackling inequalities and finding solutions. So our service offer, Newham Nurture provides specialist ESOL antenatal education bespoke to our women's situations. So providing evidence-based relevant information and increasing understanding of the UK maternity rights and maternity care. In reducing barriers to participation and mitigation, many of the challenges experienced by our women, we provide a healthy lunch, travel allowance for all sessions, interpreters, and offer close facilities. We also we also help to resource families with baby care bundles, providing essentials, including Moses basket, hospital bag, clothing, and nappies. We provide postnatal baby and me groups with music, play, and parenting workshops, family support, peer support, and also trauma counselling. We've heard already some of the barriers that pregnant women in temporary accommodation experience. Additionally, women who are subject to immigration control through the asylum process or have no recourse to public funds, these barriers can be significantly increased. A family's experiences within the hostile environment can be distressing and disempowering, and fear and suspicion in accessing services can really be accentuated. So overwhelmingly, people seeking asylum have little information about their claim, systems in the UK, and services available. The level of support that they receive is often not enough to meet their essential needs or to provide for their children. Some of these barriers to health experience during this perinatal period are, as we know, language barriers, women not receiving adequate access to interpreters, therefore not able to understand when providing informed consent, and making it difficult to engage with maternity services and communicate any concerns and understand the care and guidance being provided by their midwife. We had one woman who never told her midwife that her planned cesarean section was actually the same day as she was evicted from her accommodation, as she didn't have any interpreter and her last midwifery appointment, and there was no communication between social services and midwifery. So there wasn't a joined up approach. We see women unfamiliar with the UK maternity system, so not understanding how to access midwifery care and what support is available. This is causing a delay in registering when pregnant. Also, a lack of accessible, in-person, culturally appropriate and bespoke antenatal classes for women with English as an additional language. Of course, other than New and Nurture, which is what we provide. So we're seeing poor nutrition. We're regularly seeing high-risk pregnancies, food insecurity with pregnant women, and young children living on processed food bank provisions with a lack of fresh food and no cooking facilities. We're seeing long periods in hostels and hotels with no kitchen. Postnatally, women are formula feed report not being able to clean and sterilise bottles properly, having no access to kitchens to wash bottles, or breastfeeding mums unable to express and store breast milk as they have no access to a fridge. Sofa surfing and frequently moving. Women are told by friends that their baby will be removed if midwives find out that they are homeless. Women are fearful of the Home Office, and when moving frequently, women miss appointment letters as they are sent to old addresses and may not even know that they have actually missed an appointment. Financial insecurity. As an asylum seeker, many individuals receive only £8.86 a week allowance, making it very difficult to travel to appointments or afford the essentials for themselves and for their baby. We're seeing a lack of childcare. Women who are socially isolated with no close friends or family have no safe childcare for older children to go during birth or healthcare appointments. A fear and suspicion of services. Many women who are subject to immigration control have a fear and a lack of trust in the NHS and maternity services. Some are declining care or interventions because they're afraid to receive a large expense that they're unable to afford. Many of our new mothers have received bills of up to £14,000 that they know they're unable to afford. Social stigma and discrimination. So negative stereotypes about migrant families and reducing leading to stress, racism, and also social isolation. And lastly, trauma and poor emotional and mental health. Women are holding significant psychological trauma from previous experiences and life events, many associated with experiences in their home country and while migrating. So the photo you see on the screen is of a hotel room sleeping one of our families of 5 people, including a 7-month-old baby. There are no cooking facilities or a food preparation area, which makes it difficult for the mother, who is currently trying to introduce solid foods to her baby and trying to make the best healthy choices available within her circumstance. The family have been living in this hotel for over 2 years. And lastly, this slide is around a message that really we must be having a coordinated response to providing scaffolding for our families and finding sustainable and effective solutions to reducing inequalities. And it really must include the voices of experts by experience. So there's no need for us to be working alone. So New and Nurture are involved in numerous action and working groups locally, and also in ongoingly contributing to research and sharing our families' voices. When we're in meetings, asking ourselves, do we have all the perspectives that we actually need within this meeting? Is there decisions being made and voices that we're actually missing? Do we have NHS? Do we have local charities and lived experience? And it's important that we need to be creating respectful, honest, and safe spaces. When something is not working, we need to be brave and bold to be able to voice this when it's not working. Having clear, robust, and trusted pathways is absolutely imperative for professionals to know what support is available for families and the circumstances, how to refer, and having trust that the referral will be actioned and support will be provided. Some of the photos that you see here on the screen are from a key piece of work that we did locally to ensure that we had clear, robust, and trusted pathways that were also stress tested. Some of the solutions within some of the action groups we've come up with is around working collaboratively. We've seen a coordinated effort to resource and partner with local organisations and grassroots charities to create a food alliance, which has seen over 30 organisations providing access to community kitchens, regular hot meals, creating resources for safe preparation of formula and storing breast milk within hotels. Also public health outreaching with organisations like New and Nurture to access women who are not receiving Healthy Start vitamins. And it's important that we can provide personalised support, providing healthcare and proactive support adapted to a woman's personal situation. This may mean letting her know that she needs 6 items when her baby is born and not the 20 items that are listed within the information booklet, or printing information if they don't have access to Wi-Fi, or adapting healthy eating advice and safe sleeping advice so it's achievable within temporary accommodation. But importantly, it's about scaffolding services around our families. Scaffolding is a temporary structure that provides a stable and strong support, which is what they need. And lastly, I end with a lovely photo of some of our staff and our partners and families of New and Nurture. And this is a photo that shows the award that we received from the maternity stream of Sanctuary. Thank you.
Fabulous. That's fabulous. Thank you so much, Belinda. I think what you and Ange have really illustrated to me is the sort of importance of what your projects do very much is illustrate putting the women and families right at the centre, which is what we're all meant to be about. And yet you've also illustrated how difficult it is when the systems aren't talking to each other, which is I was a little bit taken aback, I have to say, by some of the examples you're giving, and some of the practical things are really important on this, like the hot foods and eating healthily. So thank you so much, all of you, for presenting your work so beautifully. And again, I'll say it's a huge topic. we're probably all very frustrated. We haven't got hours and hours and hours to discuss. We have got little time. And I have got a question from Debbie Garland. Now I'm looking away because they're coming up on my other screen. Regular people will remember this. So I've got Debbie Garland, who is a cultural liaison midwife in Belfast, and she's asking, do we know if there are any policies or guidance within our housing services that might protect women from being moved, especially late in their pregnancies? I know there's a protected window for women in the asylum system. Now, I'm not sure if that's a Monica question or a Sara question. And I'm very conscious poor Monica is in the middle of the night and we're imposing upon her goodwill and energy.
It's fine. I mean, I don't, Sara, do you want to go with that? But from my knowledge, there's not a protected window, and this is the problem. The problem is that if we had legislation that said you are not allowed to move anybody, then actually the women would be protected. But the reason we're seeing the problems that we're seeing are because there is nothing that stops housing, the housing authority to do that. And you know, we've all just heard how horrible it is. I mean, you can be delivering one day and be moved the next day, and that just shouldn't be happening in a country like ours. It really shouldn't. And the fact that there isn't legislation that prevents that from happening is, I mean, it just astounds me. It just astounds me. And I think that's why we're all here, so that we should be advocating for that.
I would agree with Monica that, not to my knowledge, there is protected policy, but what we also have to remember is there's 4 devolved nations, and that policy and legislation differs between them, and that's where it can get even trickier and complicated. But I'd like to maybe draw Angie in on this one, because you might know from your badger and baby.
That's what I was going to say. So if people, so I'm sorry that was so quick, but that does highlight the differences. And it is ironic that they will protect, I love badgers, but they will protect a pregnant badger and her cubs from being moved, but that doesn't exist within for our mums and babies. And so that's why the political work is so important. The APPGs getting behind organisations that are feeding through the lived experience of our families, and we try and do that really carefully, but and we try and make sure that their voice is heard, so that we can change things. And we know, again, if you go back and have a little look at that slide, it just summarises, you know, we have managed to change the advice to local authority that every baby under the age of 2 needs a safe place to sleep, a cot to sleep in, but there is more work to do, and we're doing it together. But all of the little parts, it's incredible, really, from Monica's work to Sara to Belinda, all of our work together. This is such a massive field, and there is so much to talk about. But there is a lot of work to do.
Absolutely. I mean, even just I mean, actually, it's quite interesting when you're talking about badgers, because I'm thinking, well, I don't think badgers are protected enough. So that makes it even worse for women and babies. My goodness.
But even to the fact that they talk about play space, that you can't move a family of badgers because there isn't enough play space, and you can go to jail if you do that.
Yeah.
The fact that you can't move a badger set if they don't have access to nutritious food, you can go to jail for that.
Yeah.
We move women on the day they've delivered, the day before they've delivered. You know, within 4 hours' notice, they can be expected, and they do try. Many local authorities do try, but the crisis and the crisis in stock within local authority, the pressures are just so great with this housing crisis that often it becomes difficult. And like we said, different across the country.
So that was possibly not the answer that Debbie wanted. So sorry, Debbie, that's the answer. We need to fight and make things better. And really, that's getting involved with your local politicians and getting something going in Parliament. Thank you. Okay, now I've got another question from Grace Newby. Hi, Grace, who says, how can I contact you, Belinda? I'm currently conducting a research study into homeless women's experiences of accessing healthcare during pregnancy with University of East London. I think Belinda, you had your email on there, didn't you, on your presentation?
I did at the end, yes.
And are you
Love to hear
happy
from
to
you.
take contact after this evening?
Yes, of course, no problem.
Just checking.
Yes, thank you.
Okay, so take that in mind, Grace. You can get in touch with Belinda. Fantastic. And we've got comments. Fiona Rochelle, hi Fiona, says, thank you, such an informative hour. There is some wonderful work going on. Well done. And Juliet Samuel, excellent presentations highlighting the plight of women living with homelessness, which is nice. And Diane Garland, hi Diane, says, thank you for such wonderful presentations. And Debbie's returning to Debbie's Garland, who asked at the beginning. The Home Office does have a protected window and a safeguarding email you can contact if you come across a woman in this situation 36 weeks till 6 weeks after birth. Okay, we'll follow that. I will follow that up. Thank you, Debbie. And Linda Pasqui, this is nice. This is a nice one. Thank you so much. You're angels. And I bet you didn't know that, but you are. Fantastic, fantastic people. Erin Tickle says, thank you very much for this talk. Great work, but still gaps that need addressing. Absolutely. And then we have another question from Leanne, who says, thank you so much. This has highlighted so much how important. Will resources to all your research be available on the website? I think we've got on the resources sheet. On the resources sheet, there is the QR code gets you linked to quite a lot of
QR code will take you to the infographic, and I think Monica, you've got links to your research, but obviously at the moment I'm still under review for publication, so hopefully I can actually officially get that out there and talk about it a bit more in depth once it's published. But yes, we've got links to it and stuff.
Ours is all, if you just go to the Champions Project, literally all the information of everything we've done keeps getting uploaded as we do it onto that website.
There's a lot of information, and that's why I'm going to reiterate to people who are watching, go through, you'll get a copy of the presentations. So just go through again. And actually would be really good is if you sit down and share it with colleagues, maybe on a quiet time on the ward, maybe, but really discuss it and raise the issues, because these are really important, and we need, as practitioners, to know if there are women in this situation and where we can help them, and maybe not send a woman home a day after a cesarean section if you know she's got home problems or lack of home or being moved around. I don't know. Okay, I've got another I think you've stunned the audience. I think we need to maybe I need to say to the audience, we're going to have our guest back to tell us the next bit of the story. I always like to think of this as a story, because I'm hoping the story is going to get better with this exposure. And Enya Boyle, hi Enya, says, leading lights. Thank you for paving the way for much needed provision. Thank you. And Jeremy Barrett says, thank you so much. Eye-opening presentations and fantastic work that you're all doing. So I think that's a good place to stop. Now, I always say every time that this is the fastest hour in the week. And it really is. This hour has gone so quickly. My brain, and I'm sure it's the same for anyone who's been watching, is so full of all this information and the work that you've been sharing with us. I know I'm going to have to go back and have a look at some of the facts and figures and some of the details of some of the work. I'm going to remember Angie's badger and case study, and I'm going to remember Belinda's, that little picture of the room with that family who've been in there for 2 years. That was a really strong image. So thank you so much for sharing your work with us, and we'll look forward to welcoming you back in the future, definitely. So thank you to Sarah, Monica, Angie and Belinda for joining us. Also, thank you to Angela, who's in background, making sure this is recorded so you can access it again and you can share with your colleagues. And I think I'm saying this also for students, because you might want to share this with your lecturers if they're not online as well, because this is a really important area for us to know about. It really is. Okay, and for those of you who want a podcast, this will be available at 6 o'clock in the morning on Friday, and then it'll be circulated again on Tuesday. Now, next week, we're going to be looking at supporting women with disabilities through pregnancy, birth and beyond with Dr. Myrto Kronyati and Angelina Akonma. Oh, I'm having troubles with my lips now, my mouth now. So, join us same time, same place next week. Stay safe. Don't forget to book actually for the 11th of February for the London Festival if you'd like to come. Stay safe and we'll see you next week. Thank you again.